Okay, everybody, welcome to your coagulation instrumentation lecture. This lecture can be found in your RODAG hematology book, and it's about your coagulation instruments and the different types of instruments that we use in coag. Just to take it back to a historical perspective, coagulation, the process of testing in coag dates back all the way to the beginning of the 1900s. In 1910, the coaguloscopimeter was the first clot detection instrument that was created by a man by the last name of Cotman. This meter measured a change in viscosity of blood as it clotted. It generated a voltage change that was recorded by a direct readout system. The voltage changes were then plotted against the time to measure the clot formation. In the 1920s, the plasma coagulation testing began by when Graham, another person, an innovative researcher, added calcium chloride to the anticoagulated plasma at 37 C. Graham then measured the increasing viscosity of the blood during the fibrin monomer polymerization, a principle that we use today in thromboelastography, or TEG. Nephelometers were developed in 1920, where the first instruments for coagulation testing. The instruments measure a 90-degree light dispersion of a colloidal suspension. As plasma gets clotted, a change in light scatter can be measured over time. The electromechanical clot detection technology was employed by the fibrometer, and there have been recent improvements, but they are all based on these technologies or these types of methodologies that were first discovered in the early 1900s. So obviously, analyzers nowadays offer a variety of testing. These instruments have multiple testing in them. Before, it really was simple. It was about just performing a routine PT and APTT. Now, instruments can be used to assess or to do specialized tests. And these specialized tests can now be done in hospital settings rather than having to be sent out to hospital labs. Okay, so let's talk about some different types of methodology that you'll see in the clinical lab setting for coagulation testing. And one of them is the endpoint detection principles. One of them applies the endpoint detection principle. Okay, so some of these coag tests are automated, or some of them are semi-automated. Semi-automation requires an operator to deliver the test plasma and reagents manually to a reaction queue, and basically limit the testing to one or more specimens at a time. Automation, or an automated instrument, provides more of a pipetting system that automatically transfers reagents and test plasma to reaction vessels and measures the endpoint without operator intervention. Instrument methodologies depend on this endpoint detection. One single laboratory analyzer can have multiple detection methods. For example, it can have mechanical endpoint methods, photo-optical, nephelometric, chromogenic, or immunologic. Okay, it could have some of this methodologies can have some limitations, and there have been some recent improvements with them. Okay, so mechanical, excuse me, sorry, go back to, okay. All right, so now we're good. We're in this right here, slide 5. Let's talk about the mechanical endpoint detection assays. These measure a change in conductivity between two metal electrodes in the plasma. All right, the fibrometers were these old instruments of coagulation. They were semi-automated instruments, and they used the mechanical endpoint detection methods. The fibrometers were the first instruments to be used routinely. It had a probe. The probe had one stationary and one moving electrode. So during clotting, the moving electrode would enter and leave the plasma at regular intervals. The current between the electrodes was broken as the moving electrode left the plasma. When a clot formed, the fibrin strands conducted a current between the electrodes, even when the moving electrode was exiting the solution. The current completed a circuit, and that circuit, the completion of a circuit, led to the timer being stopped. And that's what it meant to detect a clot. This is a mechanical endpoint method of detection. Okay. Some analyzers that use endpoint detection principles or detection methodology use what is called the magnetic sensors. Magnetic sensors are another method of mechanical clot detection, which monitors movement of a steel ball within the plasma. So there are two different principles employed that use these magnetic sensors: the diagnostic stereoanalyzer methodology and the AMAX in Destiny, which is also an instrument made by Diagnostica Stago. The Diagnostica Stago analyzer methodology uses an electromagnetic field that detects the oscillation of a steel ball within the plasma reagent solution. The oscillation is the movement back and forth at a regular speed. As the fibrins transform, the viscosity starts to increase in the sample, slowing down the movement. When the oscillation decreases to a predefined rate, the timer stops, indicating the clotting time of the plasma. The other methodology employed by T-Coag-US by Diagnostica Stago employs a steel ball that is positioned in an inclined well. A position of the ball is detected by magnetic sensors. As the well rotates, the ball remains in a position on an inclined position, and when the fibrin forms, the ball is swept out of that position. And as it moves away from the sensor, there is a break in the circuit which stops the timer. These instruments, specifically the AMAX and Destiny by Diagnostica Stago, the steel ball instrument methodology, is not affected by icteric or lipemic samples. So this is a graphic from your book that shows you the viscosimetric or electromechanical clot detection methodology in the Diagnostica Stago. A steel ball oscillates in an arc from one side of the cuvette to the other. Movement is monitored within a magnetic field. As the sample clots, the viscosity rises and movement of the steel ball is impeded. Variation in amplitude stops the timer at the interval, and the interval is the clotting time. Continuing with the endpoint detection principles, we're now going to talk about the photo-optical endpoint detection methodology. It is an alternate name for this is called turbidometric methodology. The photo-optical instruments detect a change in plasma optical density, OD, or light transmittance during clotting. It is the light of specified wavelengths passes through plasma, and its optical density is recorded by a photodetector. The optical density depends on the color and clarity of the sample, and it is established at a baseline. The formation of a fibrin causes the light to scatter allowing less light to fall on the photodetector, thus generating an increase in the optical density. When the OD rises to a predetermined variance from the baseline, the timer stops, indicating clot formation. Again, this is the image of the turbidometric or the optical density methodology employed in coagulation. The photo-optical instruments detect the change in plasma optical density, or OD, light transmittance during clotting. The light at a specified wavelength passes through plasma, and its optical density is recorded by a photodetector. The optical density depends on the color and clarity of the sample, and it is established at a baseline. Formation of fibrin causes light to scatter, allowing less light to fall on the photodetector, thus generating an increase in the optical density. When the optical density rises to a predetermined amount or variance from the baseline, the timer stops, which indicates clot formation. The next methodology is the nephelometric endpoint detection, or endpoint methodology. This is a modification of the optical endpoint detection, in which a 90-degree or a forward angle light scatter rather than the optical density is measured. A light emitting diode produces incident light at approximately 600 nanometers, and a photodetector detects variations in light scatter at 90 degrees and 90 degrees, and also at 180 degrees. The 90-degree angle is measuring the forward scatter. The 90-degree angle is measuring the side scatter, or SS, and the 180-degree angle is measuring the forward angle scatter, the FS. As fibrin polymers form, the side scatter and the forward angle scatter rise. The timer stops when the scatter reaches a predetermined intensity and the interval is recorded. This methodology was the first to be applied to immunoassays. As the antigen-antibody complex precipitate, the turbidity scatters incident light. In reactions where the antigen-antibody complex is too small, the antibodies are attached to microlatex particles. Coagulation factor immunoassays employ specific factor antibodies bound to latex particles. Nephelometric methods provide quantitative but not functional coagulation factors, and these are employed in complex automated instruments because they can use both clot-based and immunoassays. So in this case, a light-emitting diode produces incident light at approximately 600 nanometers, and a photodetector detects variations in a light scatter at 90 degrees, which is the side scatter, and 180 degrees, which is the forward angle scatter. As fibrin forms, or as fibrin polymers form, the side scatter and the forward angle scatter rise. The timer stops when scatter reaches a predetermined intensity and the interval is recorded. The chromogenic endpoint detection method employs a synthetic substrate conjugated to a chromophore, usually PNA, para-nitroaniline. The methodology measures specific factor activity because it exploits the factor's enzymatic properties, which are their protease properties. The oligopeptide is a series of amino acids whose sequence matches natural substrate of the protease measured. Protease cleaves a chromogenic substrate at the site binding the oligopeptide to the PNA, freeing the PNA. Free PNA is yellow. The optical density of the solution is then proportional to the protease activity, and it is measured by a photodetector. Chromogenic assays are useful in patients with circulating inhibitors because they do not interfere with chromogenic testing. They're also useful in patients on anticoagulant therapy. The test is isolated for specific chemical reactions in question, and they can measure directly or indirectly. This is an example of the chromogenic testing using factor 10 assay as a direct chromogenic assay. So you have factor 10 chromogenic assay being done here in two different stages. Stage 1 is the activator, which is Russell Viper venom, RVV, is employed, which then activates factor 10 in the presence of calcium, and that'll activate factor 10 to activated factor 10. The generated in stage 2, the generated factor, activated factor 10 hydrolyzes the chromogenic substrate, liberating PNA. Free PNA is yellow in color, and the color is then red photometrically at 405 nanometers. The amount of activated factor 10A generated, and thus the intensity of the color, is proportional to the factor 10 activity in the sample over the assay range. The next method is the immunologic light absorbance endpoint detection method. This is based on antigen-antibody reactions similar to nephelometry. Latex microparticles are coated with antibody against selected antigens. Monochromatic light passes through the suspension of latex microparticles. When the wavelength is greater than the diameter of the particles, only a small amount of the light is absorbed. When the coated microparticles come in contact with their antigen, the antigen attaches to the antibody and forms bridges, causing particles to agglutinate. As the diameter of the agglutinase increases relative to the wavelength of the monochromatic light beam, light gets absorbed. The increase in light absorbance is proportional to the size of the agglutinates, which in turn is proportional to the antigen level in the sample. This method of detection is used to identify D-dimers and can be done in minutes on automated analyzers. In this particular slide, I have a link to one of the Stago instruments that are very popular in coagulation laboratories. I've also posted this link on your Moodle course so that you can take a look at this on your own time. But Stago Diagnostica or Stago instruments have the ability of using clotting methods, chromogenic, and immunologic methods at the same time in their large instruments. They test for tests such as the PT, the APTT, fibrinogen, thrombin clotting time. You can test for extrinsic pathway factors, intrinsic pathway factors, anti-10A, anti-factor 10A, which is to detect unfractionated heparin or low molecular weight heparin or other anticoagulants. You can also detect D-dimers, fibrin monomers, anti-thrombin activity, protein C activity, protein S, lupus anticoagulants, van Willebrand's antigen, microparticles, plasminogen, antiplasmid, and TAFI. You also have the ability to calibrate the instruments or run calibrators and do quality control. So there have been improved methodologies over the years in coagulation technology. The instruments that are now used in COAG have improved accuracy and precision. In the past, tests were done in duplicates to reduce the coefficient of variation, in which generally exceeded 20%. Nowadays, in automated instruments, the testing can be done with confidence, with half the material, reducing the reagent costs. The initial accuracy and precision is established by in-lab method validations for all instruments and reagent combinations. The instruments nowadays have the ability to run random access, which is a variety of tests that can be run in order on single or multiple specimens within a testing sequence. They also have improved reagent handling. They they require reduced volumes of reagents. They use very low volumes of plasma as well. It is many instruments in COAG operate with an open reagent system, okay, which means that you don't have to, for example, if you're using a Stago instrument, you don't necessarily have to use Stago reagents. You can use alternate manufacturers' reagents. It also uses what's called reagent tracking. Instruments keep records of lot numbers and expiration dates and do reagent barcoding. The reason why this is important is because all of your reagents will have a lot number and an expiration date. And once the reagents go into the instruments, they get barcoded in, all of that information gets recorded. So the instrument will not let you work on a patient on reagents that have expired or deteriorated. These instruments that are used nowadays also have improved specimen management. They have primary tube sampling, so there is no need to separate the plasma, no need to spin down your sample. Some of them have a closed tube sampling, which means there is no need to remove the cap or the stopper because the cap is pierced by the needle in the instrument. They have flagging for interference such as hemolysis, lipemia, bilirubinemia, abnormal clotting patterns, or results outside the linear range. They also have the ability to make automatic dilutions on patient samples, on calibrators, and on controls. This eliminates the need for error by the operators and saves lots of time. New technology in COAG also have expanded computer capabilities. They have internal data storage and retrieval, so hundreds of samples can be stored, retrieved, and compiled for reports for calibration curves or QC files. They also have programming flexibility or expanded test menus. Instruments have the ability to interface with the laboratory information system, and all of them, if not most of them, have the barcoding system. So you don't have to manually input patients' numbers or medical record numbers. Rather, you just basically scan the specimen and the information for the patient will go right into the instrument. They have improved flagging, which means that the instrument alerts the operator when a criteria has been exceeded or the instrument is malfunctioning. It has reflex testing or automatic ordering based on parameters or results of prior tests. It also have the ability to graph the clot formation generated by an algorithm. It shows the operator a curve to check for clot integrity. The specimen quality is very important when using these instruments. Flags are included in instruments that will let the operator know if a sample is clotted, lipemic, hemolyzed, icteric, or if there is an abnormal clot formation or no end clot detected. Also, you would get flags from the instrument if there's some sort of malfunction, such as a temperature error, a photo optics error, a mechanical error, or a probe error. Here, in this particular table, it's from your book, and it gives you a list of advantages and disadvantages of detection systems and detection mechanisms that are employed in different coagulation instruments. So here you can read this on your own, but you have all the endpoint detection methods such as mechanical, photooptical, chromogenic, immunologic, and nephelometric. And some of the advantages and disadvantages are listed in here. In coagulation, we also have the ability to do some point of care testing. Point of care testing, or POCT, coagulation tests, have been used since 1966 in cardiac surgery settings using the WVACT for heparin monitoring in the operating room. Most point of care instruments today are handheld and permit testing patient at the bedside or self-testing, or it is used for testing infants. The results are instant. The sample volume is very small and it is very convenient to carry around. The tests that include in coagulation point of care testing are the PT and INR, the APTT, the thrombin clotting time, and other testing can also be available, such as a fibrinogen. Point of care testing for coagulation uses capillary blood or a finger stick, or blood from a finger stick, or anticoagulated blood or whole blood that comes from a venipuncture. The volume of sample is about 10 to 15 microliters that is transferred one way or another to a test cartridge, and the cartridge is inserted into a test module. Here, you'll see a table that shows you all the different types of point of care testing instruments that are available and cleared and approved by the FDA. You'll see the year that they were implemented, the type of testing that they do, the type of specimen that's required, and the kind of methodology that it employs. Some clotting assays can also be done on whole blood. For this, we use an instrument called the thromboelastograph, TEG. The principle of this is for a global hemostasis assessment. It assesses bleeding as well as thrombotic diseases. You'll take citrated whole blood that is pipetted into a cup that oscillates by 4.75 degrees. A stationary pin with a diameter of 1 millimeter, smaller than the cups, is suspended by a torsion wire in the cup. The activator here is kaolin. Kaolin is added to start the clotting. As the clot forms, fibrin links the pin to the cup, and the viscoelasticity changes are transmitted to the pin. The pin torque generates electrical signals from torsion wire that is plotted as a function of time to produce a TEG tracing. When the tracing is analyzed to determine speed, strength, and stability of the clot formation, and downstream effect of fibrinolysis. Only available whole blood assay. This is the only available whole blood assay that provides comprehensive global evaluation of functional hemostasis. The ROTEM, R-O-T-E-M, is the newer version of the TEG. In this procedure, you'll take a whole blood sample that's placed in the cuvette, and a suspended pin is immersed into the blood. An activator is added to promote clotting, and the pin rotates, and upon clot formation, the increased tension from fibrin binding the cup to the pin is detected by the sensors. In COAG, we also use platelet function analyzers, or testing to assess the function of platelets. The platelet function tests are needed to assess efficacy of antiplatelet therapy, such as aspirin, clopidogrel, and glycoprotein 2B3A inhibitors used in cardiovascular patients. These are mostly done for preoperative evaluations, and these are called platelet aggregometers. These platelet aggregometers can be multiplate analyzers, AgRam, PAP8E, or the chronolog. Here, you'll see a table that shows you a comparison of different types of platelet aggregometers. You have the companies that make them, Biodata, Chronolog, and Helena Laboratories. The names of the aggregometry testing of the aggregometers, what kind of operation, the reagents that they need, whether they use whole blood or plasma, the volume that it takes, the model type, the number of channels, and the requirements for maintenance by the staff. Other tests that assess platelet function are platelet function analyzers. The PFA 100, Verified Now, and PlateletWorks are small instruments that help analyze the function of the platelets. The PFA 100 assess the quantitative or qualitative platelet abnormalities. It is a rapid, automated, and sensitive method. It uses two test cartridges, one with ADP and epinephrine, and you're also testing for aspirin therapy or von Willebrand's disease. With Verify Now, you're looking at optical detection methods that measure platelet-induced aggregation by microbead agglutination. It uses a disposable cartridge with lipophilized fibrinogen-coated beads and platelet agonists specific for the test. This instrument uses whole blood. In PlateletWorks, the aggregation results are based on platelet counts before and after platelet activation using one of the agonists filled tubes provided in the kit. It requires 1 ml of whole blood for baseline count and 1 ml for each additional agonist containing reagent. The results for this test are obtained in about 2 minutes. Molecular testing is also performed in coagulation, but mostly to detect abnormalities or genetic abnormalities in patients with thrombophilia. Genetic mutations of factor V Leiden and prothrombin G20210A are done in the molecular lab. Testing for the MTHFR mutation is also common for patients with thrombophilia. Some of the common tests are going to be PCR-based assays. These are accurate for the detection of both point mutations and single nucleotide polymorphisms. Another common method employed in coag is the restriction fragment length polymorphism, RFLP analysis. The role of molecular diagnostics will continue to grow due to the ID or identification of new genetic mutations and polymorphisms in coagulation disorders. We'll get to a little bit more of this when we start our hematology course. Okay, so basically, it is going to be very important for the management in the lab to take into considerations all of the factors, all of the variables needed in order to select the appropriate instrument for your laboratory. So basically, test selection and instrument selection is based on a patient population. You have to select what best test menus you can have to help physicians come up with accurate diagnosis and treatments for the patients in your hospital or in your reference lab. So some of the criteria that are going to be considered in choosing an instrument for coag are going to be: what's the cost of the instrument? What are the cost of the consumables, basically? Whether or not the instrument is reliable. Also consider the service response time, if there ever should be a breakdown of the instrument. What maintenance requirements does the instrument have? Also, what is the ease of use and how user-friendly the instrument is? The throughput is also very, very important. You also want to select instruments based on the breadth of testing menu, which means how many tests can we do on a single or multiple samples. The ability to add new testing protocols, how well it will interface with the laboratory information system, how much space does it occupy in the laboratory, and what are their special specifications in terms of the use of water, power, waste rate, etc. Another thing to consider that is very important is what is the reagent flexibility? If we ever run out of a particular reagent and we must do a patient in our lab, can we use reagents that belong to other manufacturers? Also, the training program and continued training support has to be considered because the staff in the laboratory will need to be trained. And if anything evolves with the instrumentation, how can the company assist the laboratory in retraining or continue to train the laboratory staff? So those are things that must be considered in order to purchase or acquire an instrument in the lab. And these last 3 slides will show you the tables that are in your chapters in your book. And it just lists all of the different instruments and manufacturers, the kind of methodology employed, whether or not they are FDA cleared for each clot-based, chromogenic, and immunologic. For example, the diagnostic STAGO, the STA satellite, functions the way the sample handling system is a carousel system and primary tube system. The PT, PTT, and fibrinogen are FDA cleared tests for clot-based methods. The heparin, unfractionated heparin, and low molecular weight heparin and antithrombin tests, however, are chromogenic tests that are done within the same system. The D-dimer is done using an immunologic methodology. So these are things that one must consider, the flexibility and the diversity that these instruments have in order to be able to bring it on through a laboratory. So everything pretty much has to match your demographics, the demographics in the laboratory, the type of patient population that you have, and the majority of the tests that are going to be needed for your particular population, for the particular patients that your hospital serves. So again, with these 3 slides, you can just go through them on your own. You're not expected to memorize the particular instruments, but perhaps you're expected to know and to be familiar with the different types of methodologies that can be employed for the testing within coagulation. And once again, this will be posted. The link to the STAGO instrumentation will be posted as well. And if you have any questions, please let me know. Thank you.